in most cases, surgery is the answer to insufficient bladder emptying and high risk of acute urinary retention. What are the current treatment options urology has to offer for a man with benign prostatic enlargement resulting in benign prostatic obstruction? This video is an overview to introduce you to watchful waiting, lifestyle changes, medication, and the overwhelming number of surgical possibilities to reduce prostate volume, starting at the classic monopolar transurethral resection to lasers to embolization. I won't go too much into detail because there is so much to cover within a few minutes. I will be going at a very fast pace, so you probably will have to replay certain sections of the video. I will divide it into chapters that will make it easier for you to go back and forth. The most important questions I will have to answer as a urologist are these. How bothered is my patient? How is bladder emptying? Is my patient at risk of acute urinary retention? I can tell you up front that in most cases, surgery is the answer to insufficient bladder emptying and high risk of acute urinary retention. In mild to moderate cases, watchful waiting can be tried with changes in lifestyle, such as reduction of fluid intake at certain times, avoidance of beverages with diuretic or irritant effect like alcohol and caffeine, double voiding technique, etc. In mild and moderate cases, I also offer shockwave therapy since lower urinary tract symptoms are frequently unrelated to prostate size. I uploaded a video about it, check it out. Alpha blockers and 5-alpha reductase inhibitors are standard of care in more advanced disease to relieve lower urinary tract symptoms. Alpha blockers have a relaxing effect upon the bladder neck and facilitate voiding. There are selective alpha blockers like tamsulosin and silodosin, which only target a certain subtype of alpha receptors distributed around the bladder neck. And there are alpha blockers like doxazosin and alfuzosin that have a more general effect on the whole body. These are also used to treat high blood pressure. Finasteride and dutasteride are so-called 5-alpha reductase inhibitors. They block the conversion from testosterone to dihydrotestosterone. As a result, prostate volume will decrease by roughly 20 to 30% in the months and years to follow. Especially dutasteride also has a pronounced action upon irritative symptoms, frequent voiding that is. Also, PDE5 inhibitors have a strong effect when it comes to urinary bother. Viagra for urinary bother? Yes, but not quite. Only Cialis, Tadalafil, is currently licensed for this purpose. The effect is even more pronounced when Tadalafil is combined with an alpha blocker. I should mention that the combination of Tadalafil and doxazosin is not recommended because the two of them might lower blood pressure substantially. What about herbs? There are a lot of different herbs available. Some may have a modest effect, but I will skip details in this video. Each year, I send patients to hospital for an operation. Who are those? In short, men with an enlarged prostate with a high risk of urinary retention, high volumes of residual urine, or high bother scores likely to be related to the enlarged prostate. When I was a resident, we had two types of surgery: monopolar transurethral resection and open enucleation with an abdominal incision. Much has changed since then, but the overall principle is still the same: reduction or removal of the enlarged tissue within the organ to restore free urinary flow. You have to keep this basic principle in mind to follow along, because nowadays the options include resection, enucleation, vaporization, alternative ablative techniques, and non-ablative techniques. In smaller prostates with sizes between 30 to 80 ml, transurethral resection has been and still is the standard of care. This is done with a loop that you heat up with electricity. The difference between monopolar and bipolar resection is that monopolar resection requires hypotonic flushing liquid to operate in, while bipolar resection works with saline. This reduces the likelihood for possible complications should the body absorb large amounts of the flushing liquid, because too much hypotonic solution will make a mess, whereas salt water will not. Laser resection with a thulium laser could be an alternative to classic resection. The advantage of the lasers is less bleeding, among others. Open prostatectomy is reserved for large glands above 80 ml. It is the most invasive of all methods because an incision has to be made, the bladder is opened, and the enlarged parts of the prostate are peeled out with a finger through the urinary bladder. I am under the impression that this method is not much in use anymore, at least not in Germany. Here we do a lot of enucleations through the urethra with the Holmium laser. Enucleation is also able to deal with large prostates. The enlarged part is released with the laser, pushed back into the bladder, and then shredded with a special instrument and evacuated through the urethra. Recovery times with this approach are much faster than with the open enucleation. Evaporation is another laser-based method. The laser acts upon contact, and temperatures of over 100 degrees Celsius are the result, so the tissue just melts away. What about other ablative techniques? Not so long ago, a robotic method involving an ultra-high pressured beam of water was introduced. There is so much pressure on that beam that it cuts like a knife. The instrument is placed in the prostatic area through the urethra, and by ultrasound, the area to be removed is determined. The rest is done by the robot. The results are good, but the risk of bleeding is slightly elevated and long-term data are not available. A couple of years ago, interventional radiologists came up with a treatment to cut off the prostate from its blood supply, so to speak. They just put a plug into the blood vessels. This is done with a small catheter that is inserted in a large artery in your groin area, for example, and placed under radiologic control in the blood vessels of the target area. When the prostate has insufficient blood supply, it is shrinking, and that's the idea behind it. And it is indeed working. But one has to know that the prostatic artery embolization is less effective at improving symptoms and urinary flow than transurethral resection. The Rezum method is another technique involving water, which is offered and promoted via various hospitals and urologic units worldwide. However, the 2022 guidelines of the European Association of Urology don't issue a recommendation, but label Rezum as a method under investigation. Steam is injected into the prostate at various locations from the inside through the urethra. The treated tissue will perish, and eventually there will be free passage of urine again. The prostatic urethral lift, called Urolift, is a non-ablative technique. It is suitable for prostates up to 70 ml, and also this technique is done through the urethra. Under cystoscopic control, small anchors with sutures are placed over the obstructing lobes of the prostate. These sutures compress the tissue and it is pressed out of the way. Urolift has a lower rate of sexual side effects, but is inferior to the urodynamic outcomes achieved by conventional resection after 2 years. Intraprostatic injections with Botox are also done. If you want to know more about Botox, please watch this video. Botox is successfully used in the overactive bladder, but intraprostatic injections didn't have much effect, so the guidelines advise against it. Another non-ablative method under investigation is the iTind device. It is a cage-like self-cutting device that is inserted via the urethra, placed in the prostatic area and left in place for 5 to 7 days. The pressure from the rods of the cage will make deep incisions at the 12, 5 and 7 o'clock positions and widen the bladder outlet. Randomized trials concerning this method are ongoing. Now you know what is going on concerning the treatment of an enlarged prostate. Of course, this was just a short overview, more or less leaving out advantages and disadvantages. For the sake of the length of the video, I didn't address sexual function, but I will do a video about it in the future. Thanks for watching, Don't forget to subscribe. Bye bye.